56-year-old female, smoker, systemic arterial hypertension. On November 3rd, 2020, thunderclap, headache, vomiting, and tonic-clonic seizure. Neuroexamination, Glasgow Coma Scale 13, disoriented and drowsy, right third nerve palsy, and no other motor deficit. This is her CT scan. We can see there's a diffuse subarachnoid hemorrhage, but mainly over here, over the inner peduncular fossa, maybe a little bit over the third ventricle. Left sylvian fissure, not much on the right, but and a mild hydrocephalus. And a small detail, you can see that both the right and the left anteroclinoid processes are pneumatized. So we can see the air inside the anteroclinoid processes. This is very important detail. CTA frontal view. We can see here at the basilar bifurcation, there's an aneurysm pointing upwards on AP view. This is a PCA, and this is the left PCA. This is the lateral view of her CTA. This is a posterior clinoid process, and this is the basilar artery and a basilar bifurcation aneurysm. It looks like that the neck of the aneurysm is way above the posterior clinoid process in this view. This is a superlateral view. Here's the dorsal sella. This is the basilar bifurcation aneurysm. It's pointing up and slightly posteriorly, but mostly pointing superiorly. And now this is the same basilar bifurcation aneurysm, and the view from posteriorly. And this is the expected position of the aneurysm in the surgery. So this is the basilar artery, this is a posterior clinoid process, and this is the aneurysm, and this is PCA from the right side, PCA from the left. So she underwent right pteriana approach 6 days after the subarachnoid hemorrhage. This is the positioning and also this incision. This is the exposure. This is right sylvian fissure, right frontal lobe, right temporal lobe. Let's go to the video. So we start with the splitting of the sylvian fissure as usual, and going deep the auricular region. And then after opening the sylvian fissure, we have the right optic nerve, right ICA, and trying to find a gap, a window to approach, but there's no window between the optic nerve and the carotid artery. So I'm going between the carotid artery and the third nerve to see if there's any gap, any window for me to approach. No gap, no window. So I decided to go for the extradural removal of the anteroclinoid process. This is the orbital meningeal artery being coagulated and cut. So I want to expose extradurally the anteroclinoid process. So this is I'm removing the winged sphenoid, and here is the superior orbital fissure. So now if you cut the dura against the anteroclinoid process, you will not injure any cranial nerve. But you cannot cut here. You have to cut against the bone. Cutting against the bone is safe. So what I'm doing is a peeling of the middle fossa, but not that complete, exposing V1, V2, V3. No, it's not necessary. And just all you have to expose is V1, maybe a little bit of V2, just creating enough room to remove the interclinite process. So this is V1, and at this region is going to be V2. Now detaching, this is V2. There's always a venous lake between V1 and V2, and in most of the time it bleeds a lot. So now I have exposed extradurally the interclinite process. Now I'm starting to drill. First, I like to expose the optic nerve, extradural optic nerve here. So unroofing the optic canal. So this is extradural optic nerve here. Lateral to it, this is going to be the interclinite process. So once I know where the optic nerve is, I go to the interclinite process. And then, as we already saw on CT, the interclinite process, both the right and the left, are pneumotized. So this is a mucosa of the sphenoid sinus. You have to be careful. If you tear the mucosa, you might have CSF leakage after the surgery. So what I use is a cottonoid and push. Now the cottonoid has been removed, but I'm pushing the mucosa away from the interclinite process. So the mucosa is intact. And then I'm proceeding with the removal of the interclinite process. As long as if you don't open this carotid oculomotor membrane, you don't open the cavernous sinus, it will not bleed. The segment of the carotid artery over here is called the clinoidal segment, but actually it is covered by the cavernous sinus. Now we are completing the opening of the dura. You have to open a little bit laterally and then medially. First you go down following the sylvian fissure, then you go laterally and then medially. See where the superficial sylvian vein is, so I'm cutting ahead of it in order not to damage. Now stitches to hold the dura, and then I have to continue to open the dura along the optic nerve. So you see, I'm cutting the dura along the optic nerve, just like what we do to expose the ophthalmic aneurysm. This is carotid artery. Now I have to open the space medial to the third nerve to free the third nerve. Continuing, this is PCA passing just above the third nerve, then opening the arachnoid membrane, liquid membrane, lateral to the third nerve here. Assume this is a PCA. And then you can see the superior cerebellar artery. And now there's a space we call as oculomotor cistern. So there's still cisternal space of the third nerve before it reaching the roof, entering the cavernous sinus through its roof. So you can gain additional space, working room, if you open the dura just above the third nerve. You will gain a distance like this. It's very important. Then PCOM is in our way, so we have to coagulate and cut, but cut the PCOM very close to the P1, to the PCA. Don't cut close to the carotid artery because they are anterior perforating, thalamic perforating branches, arteries, exiting from PCOM at this proximal third. So you cut close to the PCA. Now I'm opening the dura over the posterior clinoid process. So this is actually called the transcavernous approach to the basilar bifurcation. Now, once you open the dura, you're opening the cavernous sinus. So fibrin glue will help to stop the bleeding. Posterior cerebellar artery. Now the bone of the posterior clinoid process is exposed. Then we have to drill. It will bleed. Patience, hemostasis, Surgicel, fibrin glue. Now we can see gradually the PCA, but I don't see the aneurysm. I don't see basilar artery. So cutting the dura, additional drilling, cutting the dura, and this is the we're starting to see the basilar artery over here. This is a posterior cerebellar. This is a PCA. This is clinoid carotid artery. Now I can see I have to dissect. I'm dissecting behind the PCA. Now we have the aneurysm, PCA, left side, right PCA, clinoidal ICA. I was going to use a fenestrated clip, but we didn't have many options, so I have to make it shorter because I needed a shorter one. So first I am placing a temporary clip over the basilar artery to reduce the flow, and then I am placing the fenestrated clip that I have drilled to make it shorter so it will fit better. The neck of the aneurysm has been already been dissected. So clipping the aneurysm and then removing the temporary clip. So the fenestration will fenestrate over the right PCA. And then I have to check if the aneurysm is clipped or not, and also if the posterior thalamus perforating arteries are free or not. This here is free. And then you can see that gradually the color of the aneurysm is changing to the blue, to become bluish or grayish, whatever you want, indicating that aneurysm is thrombosed. So this is her postoperative angiogram showing a total occlusion of the basilar bifurcation aneurysm. This is her postoperative angiogram lateral view showing the total occlusion of the basilar bifurcation aneurysm. 3D reconstruction of the postoperative angiogram showing the fenestration of the clip to fenestrate, to leave the PCA free. See, PCA is passing right inside the fenestration of the clip. So there was no additional neurologic deficit after the surgery. She already had the complete third nerve palsy before the surgery, and gradual improvement of the neurological status, and she was able to open the right eye after 1 month, and normal right eye movements after 3 months.